Well, thank you all for coming on my very first day at UAB. It's great to be here and finally getting started. I have no disclosures other than to say I spent the last 2 years of my life learning how to operate on thyroids and parathyroids with Dr. Chen, and nothing I'm going to say today has anything at all to do with that. But hopefully I'll teach you a few things and make you a little bit interested in what I'm working on. So I originally got interested in post-acute care and post-operative recovery as a resident when I started to realize what a truly profound impact surgery can have on patients' lives. And it creates very significant care deficits that really hinders patients' ability to function independently and live their lives in the way they did before they had the operation. And of course, while they're in the hospital, patients are able to recover to a certain extent from what we've done to them in the operating room, so that by the time discharge rolls around, you're really looking at two distinct groups of patients. The first group really has no further care needs at the time they're ready to leave the hospital. So these are the folks that have had a pretty uncomplicated post-op recovery. They're up and walking around on their own, itching to get out the door, and you really feel good that they can go home and take care of themselves safely. On the flip side, you also have patients that have significant ongoing care needs even after they've left the hospital. And these are the folks that may have had post-operative complications or just gotten very deconditioned from the operation. But either way, when they leave the hospital, they're not quite ready to take care of themselves on their own, and they need a little bit of extra help. And this can come in two different flavors. So there's informal support from family, friends, and community organizations, and this is usually okay for fairly basic, straightforward post-op care needs. But for anything more complex, patients rely on formal support, and that's where post-acute care, or PAC, really comes into play. And for surgery patients that need post-acute care or help after discharge, there are a lot of different options, but the three most common are providing home health services through visiting nurses and other providers, skilled nursing facilities, and rehabilitation hospitals or rehab centers. And these account for about 90% of all post-acute care referrals in general and cardiac surgery patients. There are a few other options that come up: long-term care, short-term care, and outpatient therapy. But these are generally pretty rare for surgery patients, so I'm going to focus on the first three throughout this talk. When we think about who needs post-acute care, the short answer is a very large number of patients. So over the last 15 years, the number of skilled nursing referrals has increased by 400%. The number of home health referrals has increased by 600%. If we look at the breakdown by age, post-acute care is very common across the age spectrum. So 80-year-olds, if you operate on them, they end up using post-acute care about 60% of the time after surgery. 70-year-olds, it's around 30 to 40%. And even in patients younger than 60, about 20 to 30% will rely on some form of post-acute care after surgery. So it's certainly more common in older patients, but it covers the entire spectrum of the age range. As you might imagine, this has significant implications for costs. So post-acute care expenditures in Medicare are around $62 billion every year, and that was just 3 years ago, and it's been increasing steadily ever since. It accounts for around 15% of the total Medicare budget, and it's also the most rapidly expanding cost area in Medicare. Even more importantly, in the last few years, post-acute care has overtaken the inpatient stay as the most important driver of regional differences or variability in Medicare spending. In fact, a recent study from the Medicare Payment Advisory Commission showed that post-acute care will account for 73% of differences or regional variability in Medicare spending. When it comes to figuring out how we match post-acute care settings to actual patient needs, there's not a lot of data out there to help guide decision making. Most of the work has been done in medical patients, and it's focused on the front end of things, so figuring out which patients are likely to get referred to post-acute care and which ones will benefit from it. We know patients that are older that have functional deficits or limitations, a lack of social support, complex care needs like ostomies or infected wounds, or post-op complications are often referred for post-acute care. Whereas patients that are younger, that are more functionally independent and have adequate support are more likely to go home. The question is, once you figure out a patient needs a referral to post-acute care, which type of care is the best for them? Is the patient going to be best served by a referral home with home health, or are they better served by going to skilled nursing or rehab? And there's not a lot of good data out there to help us figure out which is best for each patient. Even more importantly, there are no great metrics to measure recovery once a referral to post-acute care is made. So how do we ever figure out if we did the best thing for our patients in each individual case? And I'm going to touch on some, hopefully, answers to these questions as we go throughout and set up some of the studies I'm looking to do over the next 5, 10, or 15 years. What makes this question a little bit difficult to answer is there's a lot of overlap in services among the different types of PAC. So home health, skilled nursing, and rehab can all offer physical rehab and recovery. They can all provide IV medications and nutrition support, and they can all take care of complex wounds. A couple of the differences are for inpatient rehab, you need to be able to meet what's called the 3-hour rule. You have to be able to participate in 3 hours of rehab a day to qualify, but it's kind of a shaky standard. The other main difference is cost. So rehab tend to cost more than skilled nursing, which costs more than a home health for the same episode of care. Even though there are a lot of overlap in the services among the different types of PAC, there's often an impression that home health, skilled nursing, and rehab serve very distinct or different populations of patients, but the reality seems to be quite different. So the chart we're looking at here is from a prospective study commissioned by the Medicare Payment Advisory Commission, looking at the different characteristics of patients in each of the different PAC settings. So the y-axis here shows the patient's capacity for self-care, with higher values indicating that patients are better able to take care of themselves. The x-axis shows mobility, again with values farther along to the right showing patients are being more mobile. And what this shows us is the two boxes in the far right, skilled nursing and rehab, are basically treating the same patient populations, very similar in terms of mobility and self-care. Home health tends to take care of a more wide array of patients in terms of their characteristics, but there's this core group shown here in red that's essentially identical across all three types of post-acute care. And what this really tells us is the same patients are being treated in very different settings with no clear idea of why one patient goes home with home health and the other one goes to SNF or rehab. So there's a lot of room for improving how we use post-acute care. There's a follow-up study also commissioned by MedPAC looking at whether patients could be effectively shifted from one PAC site to another. So this group used Medicare data and looked at patients in skilled nursing facilities, and they found about 20%, based on their characteristics, could potentially have gone home at the time of their discharge rather than ending up in a nursing home. When they looked at patients who were sent to rehab, around 18% could have been treated in skilled nursing and about 12% in home health. So if you add this up, it means around 50% of patients in Medicare getting PAC could have gotten their therapy at an alternative site with potentially equivalent outcomes. And about a third of patients who ended up either in nursing homes or in rehab could maybe have actually gone home and been treated there instead. So again, a lot of room for improvement. Potential benefits from a health system standpoint, there's the issue of cost savings. So as I mentioned, skilled nursing tends to cost a lot more than home health. So every patient you shift from skilled nursing to home health would save about $10,000 for every 30-day episode of care. If you send someone home instead of to rehab, you save around $25,000 per episode of care, and it's about $15,000 from rehab to skilled nursing. So this group estimated, depending on how much you shift from one setting to another, Medicare could be saving up to $7 billion a year by a more effective use of post-acute care. Equally important, several groups have shown equivalent outcomes for certain conditions such as stroke, COPD, and diabetes. There's also the issue of patient satisfaction. As a rule, patients and their families are a lot happier at home than in the hospital or nursing homes or rehab. So there's a possibility of improving outcomes, making patients happier and saving a lot of money for the healthcare system. So in summary, there's not a whole lot known about how we choose among the different types of post-acute care. There's a fairly poor understanding of outcomes, especially for surgical patients who require PAC. So a lot of potential for improving quality and cost effectiveness. And as a healthcare system, we're probably overusing skilled facilities such as nursing homes and rehab and underutilizing home health. Having given a little bit of the background of what we know right now about post-acute care, I'd like to present 3 basic studies that we've been working on over the last 5 years or so. Some of this is published, some of it's in the process of publication, and some of it's under submission. We'll basically talk about PAC and outcomes for surgery patients, focusing specifically on survival after cancer surgery. Talk a little bit about our work looking at variation in PAC specifically for surgery patients, and also some of our initial work looking at improving decision-making for post-acute care. So starting out with PAC and survival, as I mentioned, the patients who get referred to home health, nursing homes, and rehab tend to be worse off or have complicated post-operative course before they leave the hospital. So we expect them to do worse at baseline than patients who are able to go home. On the other hand, post-acute care is designed to make up for that gap and help these patients do better. So the study question we're trying to ask here is whether that actually works. Can post-acute care actually compensate for the adverse survival effects of complicated post-operative course or post-operative recovery? And we hypothesize that discharge to PAC will still be associated with worse outcomes even after controlling for other factors. So the reason we did this study is, again, we expect PAC to help patients recover and want to know how well this is working. There are some other studies out there showing worse survival after discharge to PAC, but there are a lot of methodologic issues with these studies that make the conclusions a little bit questionable. We also thought it was important to be able to set expectations for the family. So when the family comes in and they're planning what happens next, we want them to know what they can expect when their loved one is going to a nursing home or a rehab center instead of going home after the operation. And of course, we want to figure out if there's actually room for improving the system and giving better outcomes for our patients. Now, of course, this is a little bit easier said than done. So if our main outcome is mortality, and we want to look at the relationship between PAC and mortality, you can't just draw a straight line between one and the other. There are a lot of things that affect mortality. For cancer patients, obviously cancer stage is important, but there are a lot of factors that are related to a need for post-acute care that also affect mortality. And you have to adequately control for all of these factors to draw reasonable conclusions. Most of the data sets that are existing right now don't let us do this. So NSQIP, the National Surgical Quality Improvement Program, will do great for surgery. Controls for all the post-op complications and comorbidities, but it's very short-term follow-up, 30 days after surgery, and there are no cancer variables, so that doesn't really work. From a cancer standpoint, there's SEER Medicare and also the National Cancer Database. They're great for cancer, but terrible for surgery and post-op complications. So none of the data sets that were out there really met the criteria we were looking for to do the study the right way. So we had to build our own data set. And our solution was to dive into the VA system. So the original Surgical Quality Improvement Program came from the VA or VASQIP. It's basically the same thing as NSQIP with comorbidities, complications, and very importantly, patient functional status. VA also maintains a cancer registry that looks at stage and other cancer variables. They have a VA inpatient file to tell us where all the patients are going after they leave the hospital. The VA vital status file is a great long-term follow-up and gives us information on how long the patients are living. The only downside of this data set is the home health indicator in the VA is just terrible. So we couldn't really look at home health separately from the other types of PAC. So we focused the study on patients who are discharged to skilled nursing or rehab. But otherwise, it was a pretty good data set. So the way we set up the study is we looked at every veteran having colorectal cancer surgery over a 10-year period from 1999 to 2009. That's about 14,000 patients. We excluded those with stage 0 or 4 cancer, patients having multiple procedures, anyone with an unknown discharge destination, or anyone where we couldn't effectively match the date of surgery to the patient data. And that gave us our population of about 10,500 patients. To control for all the differences in comorbidities, complications, functional status, and so on, we used a propensity matching scheme of 3-to-1 match between patients who were discharged home and those who were discharged to a facility, and that gave us our population of about 3,000 patients for this study. So we first looked at how well the match worked, matched on the basic factors, age, marital status, comorbids, complications, and so on. It was a pretty good match except for one thing. The functional status was a little bit off between the groups, but it was now close enough where we could do a regression adjustment and it worked pretty well. We had a great match on tumor values, such as tumor site and stage. And we looked at the survival. There's a pretty stark difference. The home group is shown in green, the post-acute care group is shown in red, and it's about a 30% difference in survival at 5 years between these groups in the unmatched population. When we did the matching scheme, there's still a pretty significant gap of 15% difference at 5-year survival. And more importantly, when we broke it down by stage, we saw some fairly shocking results. So this is stage 1 cancer. Again, green is discharged home, red is discharged to post-acute care. And if you look at the end of this chart, it's basically telling us that if you're discharged to either a nursing home or rehab after your cancer surgery, stage 1 colorectal cancer, your 5-year survival is 45%, which means your survival is about the same as if you had node-positive disease. In other words, from a prognostic standpoint, going to PAC upstages you from stage 1 to stage 3 cancer from your survival standpoint. And we saw pretty similar gaps for stage 2 and also for stage 3. And we did the more sophisticated matching analysis for the unmatched groups. The difference in the likelihood of death was about 2.4 times for the unmatched population. Once we did the propensity matching and the adjustment for functional status differences, patients who were discharged to PAC were still about 50% more likely to die at any given time point than patients who were discharged home. So in summary, we found that PAC facilities don't totally compensate for differences in post-operative recovery. Sending patients to a skilled facility is essentially equivalent to having node-positive disease or nodal metastases. The differences don't all seem to be explained by patient differences in comorbidities, complications, and functional status, and we really need to improve our preoperative preparation and post-operative recovery to help patients bounce back better from cancer surgery. So that's the prognosis end of the picture. We next wanted to look at variability in PAC utilization and get a little bit more into the cost effectiveness angle of how we use PAC. So what do we learn from variability? Probably everyone in the room is a little bit familiar with this picture from the Dartmouth Health Atlas, showing variation in Medicare spending across regions. And the basic idea is you have the same patient getting very different care at very different costs depending on where they have their surgery. And this is a huge driver of the very high healthcare costs in the US. So looking at variation in the use of care shows us potential areas for improvement and how we can deliver more cost-effective care. We know there are a lot of things that can influence the rate of PAC referrals, so the availability of care. There are only so many ways to climb a wall. If you don't have skilled nursing in the neighborhood, you can't refer the patients there, so that's certainly going to be a factor. Funding in terms of the patient's finances and also their insurance, what they can afford dictates what they can get after leaving the hospital. There's also patient preference, and we've all met people that absolutely refuse to go to a nursing home no matter what. They're going to go home, and that can influence the rate of referrals. And of course, hospital factors, whether the hospital owns a PA facility or not, the relationships to the surrounding providers can all influence the rate of PAC referrals. So the basic study question we wanted to answer in this study is how much variability is there in the rates of PAC referral after complex surgery? And the hypothesis is there's going to be a lot. So to do the study, we combined VA data with non-VA data. So we looked at all complex cardiovascular and abdominal surgery in the VA system over a 4-year period from 2008 to 2011. We looked at all the patients who were discharged home versus those who were discharged to facilities, again, nursing homes or rehab. We did the same thing in the nationwide inpatient sample, which is a larger representation of the US. So combining the VA and the NIS gave us basically a comprehensive picture of all healthcare in the US, including Medicare and non-Medicare patients. And our primary outcome was the risk-adjusted ODE ratio for discharge to PAC compared to home. The surgeries we studied, from abdominal standpoint, colorectal, pancreas, and liver. Cardiac, we looked at bypass and aneurysm repair, and vascular, we looked at peripheral vascular bypass. This is showing the overall rates of discharge to PAC in the VA in black and the NIS in gray. The overall rates, so the VA is right around 10% and the NIS is around 20%. And again, this is capturing all patients of all age groups. As a rule, the VA tends to use PAC a little bit less than the hospitals outside the VA, with the biggest gap in aneurysm repair. We triple and quadruple checked this because I didn't quite believe that more than 40% of AAA patients outside the VA were sent to nursing home or rehab. It really wasn't a typo, it seems to be legit. But everything else seemed to be pretty close in terms of the VA and NIS, with a little benefit to the VA. So starting out looking at the VA system, we broke VA hospitals down into high, medium, and low volume centers. So the charts at the top are basically showing the raw rates of discharge to either nursing home or rehab for each hospital in the VA system. And as you can see, there's a fair amount of variability. So depending on where the patient had their surgery, there might be a 2 to 3% chance of referral to PAC, and it also can be as high as 40%. Pretty good range. The bottom charts are showing the risk-adjusted observed to expected ratios, so whether the hospital is sending more or less patients to PAC than you'd expect from their risk profile. And again, pretty wide range of variation. So some hospitals, the OD is about 0.1, and other it's as high as 4 or 5. So a wide range of variation depending on where the patients had their surgery. Same thing for the NIS. This is just showing again on the x-axis the percent discharge to PAC and the y-axis the number of hospitals. So the rate of discharge from each hospital ranged from 1 or 2% to as high as 60%. And if you risk adjusted it, most of the hospitals are in the range of less than 1 to 2, but there's some significant outliers with hospitals sending 2, 3, or even 4 times as many patients to nursing homes or rehabs than you would expect from the patient's post-operative course and their preoperative characteristics. And what does that mean in practice? Basically, some hospitals will send 90% fewer patients to PACs than expected, and others will send 3 to 4 times more than you might expect. And again, we looked at survival just to kind of see, and once again, 5-year overall survival is under 50%. So not only a lot of variability, but pretty poor outcomes across the US hospital system. So in summary from this study, there's a lot of variation in the use of home health and skilled facilities for post-acute care needs. The chance of a patient going home after surgery is very much dependent on which hospital performs the surgery. And again, only about 50% of patients discharged to PAC are going to be around 5 years after their operations. So there's a lot of variability. What can we do about it? Our next study is trying to make some preliminary roads to figure out what can we do to really make PAC decision making more rational and evidence-based. So the study question we wanted to start with are how similar are patients discharged to skilled facilities, again, skilled nursing or rehab, compared to those who are sent to home health to address their PAC needs. And our hypothesis was, based on some of the Medicare data I showed you before, that they're going to be pretty similar. Now this chart I showed you earlier showed that about 50% of patients could be treated at a different setting, and about a third of patients sent to skilled nursing or rehab could have gone home. The downside of this chart was it's based almost entirely on medicine patients, so heart failure, COPD, stroke, that sort of thing. It's not specific for surgery patients, and we know that after surgery we use PAC for very different reasons than for medical patients, so we wanted to study this more directly. And what we're really trying to get at is what kind of patients after surgery go home with home health, and which ones end up in skilled nursing or rehab. So if everyone who goes home looks like this, and everyone who goes to nursing homes looks like this, there's probably not a whole lot we can do to improve decision making. But if it looks more like this, if there's an equivalent patient for everyone we can find, that tells us the process of deciding who goes where could potentially be improved. So to figure this out, we used a nationwide inpatient sample, again focusing this time specifically on colorectal surgery patients. We had about 54,000 patients that were discharged to post-acute care. Out of that group, around 23,000 went to either nursing homes or rehab, and about 30,000 went to home health. So these are the two patient populations we're trying to compare. We wanted to figure out what predicts whether patients go home or whether they go to nursing homes or rehab. So we used initially a regression approach and split this entire population into a test and validation sample. Used multiple regression with bootstrapping to figure out if our model is any good, and it worked out okay. The C statistic for the model was about 0.81 for the test and about 0.8 for the validation, so a reasonably decent model. And what we found is for surgery patients, the predictors of going to skilled nursing or rehab instead of going home include age, female gender, having emergency surgery, insurance status, length of the hospital stay, number of post-op complications, their functional status, and any mental health problems. And that gave us a preliminary model for figuring out who does what and who goes where. We also wanted to take another approach to make sure we're really getting this right. So we used what's called a classification and regression tree, which is an alternative to the standard regression modeling. Instead of trying to figure out what are the predictors of who goes where, a card analysis basically tries to divide patients into increasingly smaller groups that are more and more similar, and then figures out what are the characteristics that create that similarity. From a statistical standpoint, it tends to be a lot better at uncovering complex relationships in regression, and this was a nice way for us to make sure we're modeling things correctly. So the card analysis basically told us the biggest factor overall for PAC is age. So if we look at just the patients who are younger than 70, the next thing that helps us figure out what are the differences in the patients is their estimated mortality. It told us insurance status is also important, length of stay, and number of complications, so kind of the same things from our regression model, and that made us feel pretty good. For the patients who are older than 70, again, mortality is important. And then it starts breaking down in terms of neurologic disorders, length of stay, emergency surgery, and the hospital region. And again, this gave us pretty similar information to the regression model, but showed us how we can adjust the model in a way that gives us a better understanding of who goes where in terms of post-acute care. And that's really important for our next step, which is trying to calculate the probability of going home versus not going home. And that helps us get at the question, could the patients who are ending up in nursing facilities and rehab really have been treated at home instead? And to figure this out, we use propensity matching in a little bit different way than traditionally is used. So the first study I showed you basically used a match to create two similar populations for analysis. This time we're working a little bit backwards. We wanted to figure out if we could actually create good matches to figure out how similar are these two populations. And what we're really looking for is, for every patient that goes home, can we find a similar looking patient who went to a SNF or a rehab? And if so, that tells us one could have been shifted to the other and vice versa. So this is our matching diagnostic from the propensity score. And when it works, what you really want to see is all the values should be between those two vertical red lines. So every line, every X and dot on this graph represents one patient characteristic: age, complications, insurance status. The unmatched population here shows a wide range in variability, meaning the populations are pretty different. When we run our match, everything falls within that magic range of about 10%, which tells us we're getting a pretty good match. So by combining the regression, the card analysis, giving us a propensity score, this is telling us our matching scheme works, and we're finding out whether the patients are similar or different. And this is what the propensity score actually looks like. So the y-axis is the predicted probability of discharge to skilled nursing or rehab versus home. And we broke it down into quintiles. So this group over here are patients that our model tells us ought to be going to skilled nursing or rehab. The patients in red actually went home, and the patients in yellow actually went to a SNF. And what this is telling us is even in the highest probability group, patients, our model says these folks should definitely go to skilled nursing and rehab, we could still find patients who went home that look essentially identical. Same thing at the bottom end of the spectrum. So right here are patients our model says these folks should be perfect candidates for going home. But even in that group, we're still finding patients that were sent to skilled nursing or rehab. When you add this all up, what we basically found was 61% of patients who ended up in skilled nursing or rehab had an equivalent looking patient who went home. In other words, potentially up to 61% of patients who went to skilled nursing and rehab could potentially have been sent home instead. As I mentioned before, with more cost savings, potentially equivalent outcomes, and a lot happier patients and families. And in terms of actual cost, if we look at Medicare data, there's anywhere from a $5,000 to $25,000 difference between sending patients home and sending them to skilled nursing and rehab. So we wanted to figure out how much could we save by shifting more patients home. So the y-axis is the cost savings in millions. The x-axis is how much we're shifting patients from skilled facilities to home. And what we found is you can save anywhere from 10 to 15 million to up to $400 million a year by a more rational approach to PAC after surgery. So a lot of room for cost effectiveness within surgery post-discharge planning. So in summary, there's a lot of overlap between patients who are sent to home health, skilled nursing, and rehab following surgery. There's a lot of room for improvement in getting more patients home after their operations. There's potential for significant cost savings for the health systems, although it's not yet clear why some patients are getting different types of PAC, why one person goes home and one person doesn't. We're hoping to dig into that going forward. So that sets up the future work that I'm hoping to do over the next 5, 10, 15 years. I want to understand what's the basis behind PAC decision making. So the stuff we've done so far has been based on big databases. It can tell us a big picture, but it doesn't tell us why a particular decision was made. And that's where qualitative research techniques really come into play in helping us understand what drives these individual decisions. We want to figure out how to select the best PAC type for each patient so everyone gets the best outcomes. And we want to have a better definition of what success means from a patient perspective. How do you know you did the right thing for each patient in each individual case? We also want to figure out what are hospital or system factors that drive PAC use. And of course, we want to understand how formal and informal support networks interact during recovery. And that maps out the next 20-year plan of things I want to answer. So thank you very much for listening. And of course, thank you to all the great people that helped out to make these projects possible. I'm happy to answer any questions. One step at a time.
Dr. Hessel. Yeah, thanks, Courtney. That was a great talk. I guess one sidebar question is, do you think that the increased use of PAC is due to an unintended consequence of pressure on length of stay? And you know, it's we see it in, you see PAC in isolation, it sounds like, but if you look back a little further, so that's question one. And then two, it makes you worried when you see survival is only 50%. And again, looking earlier, are there people that shouldn't have had operations in that population? And can we select that better? Or, as you say, can we figure out how to make them have a better chance of surviving their PAC? Right? I mean, is your survival, because you're essentially saying you're not doing your job. So if I owned a PAC, I wouldn't hire you to make me look bad because you just said I'm not doing my job. So that's the second part. Selection up front and pressure on an unintended consequence.
No, those are great points. So I think you're absolutely right. So you can see the almost linear correlation. As length of stay goes down, use of PAC goes up. And there's some great studies, I think, out of the trauma and acute care literature basically showing that SNFs and rehab have now become the surrogates for what used to be a hospital stay. So we're essentially saddling them with our complications. And to a certain extent, it helps game the system, or at least it used to, because people had their complications in SNF. It didn't count against the hospital. But now that we're being paid for essentially the entire episode of care, it's mattering again. So we can ship the person off to a nursing home, but they bounce back 5 days later, it's still on us to try to fix it. And I think from a prognosis standpoint, again, you hit the nail right on the head. So these patients are doing very poorly. The question is why? So I think to some extent, there's the issue of how do you measure quality of someone who goes to a SNF or a nursing home or gets home health. So within Medicare, the methods that Medicare uses to measure outcomes and quality in each of those different types of PAC is different. They use different measures with different ways to measure the same things at different time points. So anyone trying to analyze this in Medicare basically whacks their head against the wall a couple hours a day trying to make sense of it. They're shifting that to make it a little bit easier, but they're not quite there yet. So I think, first of all, we need good measures of what it means to deliver quality post-acute care. But on the flip side, as you mentioned, some of it's also patient selection and who gets offered surgery. And traditionally, we haven't done the best job, I think, talking to patients. So yes, I can offer you this operation. Yes, most of my patients do well, but you're a 90-year-old smoker who spends his entire day in a wheelchair. If I do this big operation, pretty good odds you're gonna end up in a nursing home afterwards. And bringing that into the conversation with patients, I think there are legitimately folks who will say, oh, I never thought about that. You know, I'm actually feeling okay. Maybe this surgery thing isn't such a great idea. So I think that can figure into the equation of the conversation with patients. But there's also the element of getting patients ready for surgery. So doing prehab, exercise, smoking cessation, weight loss to help people get ready. And in the hospital, I think some of the EROS and enhanced recovery are great ways to help patients bounce back faster. And there's a lot of data showing we're underestimating what patients can do. So we're worried about hurting older patients, getting them out of bed and running around. The reality is, get them up out of bed, get them moving, getting eating, they do better and don't need PAC as much.